Hello. In today episode, we will talk about some tips and tricks and some general information regarding the biomechanical consideration and the treatment planning, in addition to some occlusion principles that we should have information. Anti-law is one of the most important laws that we first learn in the prosthodontics. It states that the root surface area of the abutments must be less than the root surface area of the teeth being replaced. So, when we want to replace a single missing tooth and an implant is not an option, we go to the 3-unit fixed denture. But we have two exceptions to this. The first one is when we have a maxillary or mandibular canine tooth and we want to replace it. So in this situation, we incorporate a small lateral incisor to the central incisor to prevent the lateral drift of the bridge. And this method of using two adjacent abutments is called the double abutting. Another exception is when we are replacing a maxillary lateral incisor, so we can cantilever it from a single distal retainer on the canine. In the cases where we have multiple missing tooth and we have multiple insertion line, here we can use what is called a key and a key way of a metal cast was fabricated to decrease the stress. The metal occlusal surfaces were used because the patients had the paroxysm habits. These non-rigid connectors are used for metal ceramics only, where they are only be made from ceramic and cannot be made from zirconia or lithium disilicate. The more we increase the gap between the teeth and the pontex, which means the more we increase the number of the pontex, the more movement we get and the prognosis decreases. For example, here, when we had two pontex, the deflection has increased 8 times, and when we have 3 pontex, it it increased to 27 times. So a bridge of one pontic has the most favorable prognosis. An exception to this scenario is when we have a complete denture. When it occludes low, the tend to be lower. So it will not cause stress on the bridge regardless of its long length. Another successful bridge is the mandibular anterior region, where we have 6 units from the canine to the canine. As for the maxillary arch, when we want to replace the 4 anterior, um, it is favorable to incorporate with the canines the first premolars, at least from one side. A nice information is that the reason retained bridges had more successful where they cantilevered in comparison when they were bonded on both sides, with tooth movement causing bonding failure, which means that cantilever designs are showing more successful results when they are bonded to one side only. Cantilevers can be used with an implant-supported prosthodontics, which means that we can cantilever a pontic to an implant. When complete dentures are opposing to a fixed bridge. They may get wear by time due to the difference in the material between the two uh, restorations. Now we will discuss when we have a complex restoration of both arches, how we can maintain the vertical dimension throughout the procedure of treatment. First of all, we take the central relation record and the face bow of the patient. Here in this case, they had an edontless mandibular in the back, so we used a record base to take the relation. In this cast, we made a replica for it. The first one was mounted on the articulator. Then it was waxed to the final prosthetic results that we are aiming for. At this stage, if the aimed restoration was a denture, so we mount the teeth on the diagnostic waxed cast. After we do a preparation to one of the casts, here we did it for the mandible. We mounted against an unaltered cast in the central relationship. After we get it in position, we remove it and we mount the diagnostically waxed cast. Then we build the final result of the mandibular cast, and we mount it in the patient's mouth. Then we start doing the maxillary arch preparation, and we take new central relation and face bow. Then we mount the mandibular cast of the restored mandibular arch of the patient against the definitive cast and start the building that has the complete resemblance of the waxed we did in the first time. In this chapter, we will review the anatomic structures important to the study of the occlusion, and we will discuss the movement of the mandibular jaw. Also, we will see what is the difference between the ideal and the pathologic occlusion, with some guidelines about the initial phase of occlusal treatment. The temporomandibular joint is capable of doing both hinging and gliding articulation. The condylar process is covered with avascular fibrous tissue, and the articular disc is also a connective tissue that is also avascular in its anterior portion, but posteriorly we have a highly vascularized and innervated connective tissue that is called the bilaminar zone. This is the disc and this is the condylar process. The disc in its anterior portion is attached to the superior lateral pterygoid. In its middle portion or the upper portion, it is filled with a fluid that permits the movement, and it's in its posterior region. It is so vascular. There are 3 pairs of ligaments that are associated with the temporomandibular joint. The first is the sphenomandibular ligament. It has nothing to do with the movement, but it helps the carrying of the mandible. The stylomandibular ligament, it restricts the protrusive movement of the mandible, and the temporomandibular ligament, it restricts the protrusive movement of the mandible and helps in the gliding transition of the joint. Also, the muscles of mastication and the suprahyoid muscles function in the movement of the mandible. The Posselt's three-dimensional representation. It is the diagrams that reflects the movements of the mandible, starting from the protrusion where the incisor, the lower ones are initially guided by the lingual concavity of the maxillary anterior teeth. As a result, the posterior tooth contact is gradually lost as the incisors reached the edge-to-edge position. As the mandible moves farther protrusively, the incisors slide over a horizontal trajectory that represents the edge-to-edge position. Further protrusive movement of the mandible takes place without significant tooth contact when we reach to the maximum protrusion possible. The maximal open position of the mandible is represented by the lowest point in the diagram. In the morphology of the condylers process can alter the tooth contact during the movement. For example, if the patient has a steeply sloped eminence when they are moving their mandible during the lateral and protrusive extrusions, it results in an early separation of the posterior teeth. The clicking may also be associated with internal rearrangements of the joint. A patient with a unilateral clicking during opening and closing, in conjugation with a midline deviation, may have a displaced articular disc. The midline deviation typically occurs toward the side of the affected joint. For the detecting of the clicking joint, palpation and the angle of the mandible is generally more effective than the palpation over the lateral pole, because less tissue is interposed between the clinician finger and the underlying osseous tissues. If the patient's chief complaint involves the temporomandibular joint, the examination must begin with a thorough history of when the symptoms began. If the symptoms were preceded by a traumatic event to the face or the head, and the extent of the quality and quantity of the pain the patient is experiencing. Such traumatic event might have occurred years previously and initiated loosening or tearing of the ligament of the articular disc. Also, we must have a digital palpation of the muscles of the head and neck to include the joint itself. We must record if there is a comfortable opening, the maximum wide opening, the right and left extrusion and protrusive movements, deviation from the right and left hinging and translation of the mandible should be noted. The mandibular growth is influenced by the eruption of the permanent first molar into the normal angel class 1 relationship. As the maxilla grows forward, the molars attempt to remain in these angel class 1 occlusion, thus stimulating the growth of the condyles posteriorly and superiorly. If this continues through puberty, A normal angel class 1 maxilla-mandibular relationship will be the result. If, however, a traumatic event occurs, causing a disc placement from the medial pole, growth may not continue, and with the maxilla, resulting in an angel class 2 tooth relationship. We will talk about the myofascial pain dysfunction. It is a diffuse unilateral pain in the pre-auricular area with muscle tenderness, clicking or popping noises in the contralateral temporomandibular joint. And there is a limitation of mandibular function. Often the muscles are the cause and not the temporomandibular joint. But over time, the functional problem may lead to organic changes in the joint. There are three major theories about the cause of this syndrome. The first one is psychophysiologic, which means that the paroxysm and the clenching that is happening is causing the chronic muscle fatigue and leading to a muscle spasms and an alteration in the mandible movement. So the treatment should focus on emotional rather than the physical therapy. The second theory is that the muscle theory, which means that the continuous muscle hyperactivity is responsible for this. Pain is referred to the temporomandibular joint and other areas of the head and neck region. The third theory is the malocclusion of the tooth displays the condyles and the feedback from the dentition is altered, resulting in a muscle spasm. It is difficult to get to the correct diagnostic because the multiple causes and there is so many places that the patient can feel the pain from, so the precise detection of the source of the pain is a bit difficult. We use what is called an occlusal device therapy. These devices are worn for 8 hours during sleep, and if they were worn more than that during the day, they will act as an orthodontic appliance coding tooth movement and malocclusion. When we see a severe wear on the occlusal surfaces of the device and also some perforation of the molar location, it is an indication that the patient is wearing them in the right time for the right duration, and a new occlusal device is indicated. If the patient has their paroxysm action on the daytime, so the device is indicated to be worn on the awake hours. These devices can be made by a digital design. After we take an optical scans of the occlusal record with a given increased occlusal vertical dimension, it is usually recommended that the device is 2 mm in thickness, increasing the occlusal vertical dimension by 2 mm between the most posterior opposing teeth. Here the casts are evaluated on an articulator. Here we can see the outline is being designed and drawn. Then it is time for the printing using a sensitive resin. Here the material is being mixed and poured. Then they are printed in layers. This is the final completed device. Some final polishing, trimming, and the device, when it is cleaned, it is allowed to dry for 10 minutes, and it is placed in an ultraviolet violet light source for 15 minutes for post polymerization is the CCAT function software system. It combines the data from the three-dimensional radiograph analysis, also a mandibular motion tracking system. This is it. And we get a dynamic reproduction of the condylar fossa relationship, a difference between a complete denture and a normal occlusion is that a balanced occlusion provides stability because there is an even contact between all the teeth in each extrusion, which means that there is no separation between the mandible and the maxillary posterior teeth when the movement to the left and right is being made. On the contrary, in normal occlusion, when we do a unilateral movement, only posterior teeth on the working side is attached. Occlusal therapy should be initiated and completed before any substantial restorative care is undertaken. That's it. Salam.